COVID-19 has been a huge challenge to the whole healthcare community, and particularly those working in cancer care. And there are a number of key themes as to how we have modified therapies and our delivery of therapies in order to be able to continue to treat patients who need to be treated during this really difficult time. And now I think that as we see the numbers starting to reduce, it's a question of trying to readdress the balance, because it was quite easy to say, look, we have to stop this various activity. But now, we need to continue to be able to diagnose patients, we need to be able to continue to treat patients, and clearly we need to be able to continue to participate in clinical research, all of which, the latter have been largely suspended over this difficult time. And so we've had to reorganize the way we deliver our service and really to think about how we may deliver therapies differently. So I think the overriding principle in terms of delivery of the service is that we've tried to minimize patients' attendances in hospitals so that they can continue to self-isolate as best as they possibly can. So that's meant a move to telephone consultations, a move to video consultations, which actually work really successfully and are really quite convenient for the patients, and models of, for example, taking bloods in the community or perhaps in hubs that are away from the main hospital. Now, there are some challenges around telemedicine in assessing patients, but I think all of us have become fairly adept at this, and I think it's been a great bonus in terms of keeping patients out of the waiting rooms. Many hospitals have adopted the delivery of cancer care in areas away from patients who may potentially come in with COVID, and even on completely different sites. And we've had my own hospital, we've had a massive reorganization, and we're able to deliver at a completely separate site from the main hospital campus, which I think is a real improvement. So kind of that's the principles of us changing our operational delivery. We are screening patients who are about to undergo systemic anti-cancer therapy. We are screening patients who are coming into the hospital who require inpatient stays. And we are patients who have been exposed to COVID, we are keeping them continuing their therapies when they restart and looking after them in separate day case areas. How have we approached therapeutic delivery? Well, that's again about a balance, and the balance between the need for the patients in terms of management of their malignancy, but also the competing risk of the contraction of COVID and how potentially unwell patients may become. We've seen from data that patients who have malignancies have a worse outcome from COVID, and we can see that outcome is prolonged actually, and that patients even 5 years after completion of therapy for hematological malignancies have an excess of mortality compared with the general population. So it's really important that we protect our patients. So how are we modifying therapies? Well, in patients with diffuse large B-cell lymphoma and other aggressive malignancies, largely it's been business as usual, because of course these are curative malignancies. We have thought about using more growth factors in these patients, and perhaps some of the activities where there's greater debate about the benefit, maybe we have reduced. And so that might include the use of CNS prophylaxis. It may include the use of radiotherapy to bulk, for example. We've continued to deliver high-dose chemotherapy for patients who are at the highest risk. So for patients with aggressive lymphomas, where again the procedure is undoubtedly curative in some patients. That we have had to reflect hard in terms of CAR T-cell activity. Obviously, there is a demand upon intensive care resources. However, CAR T-cells are a clear benefit to many patients with relapse and refractory diffuse large B-cell lymphoma. So the program has been able to continue, but we recognize that we've done that with the full knowledge of our intensive care unit colleagues, because obviously they've been under tremendous strain. Some of the regimens we may have selected, perhaps using less immunosuppressive or myelosuppressive regimens. So perhaps where R-CHOP 14 was used before, perhaps using R-CHOP 21. We don't use a particularly lot of dose adjusted EPOC, but in those circumstances, not use that. For those patients who have more indolent B-cell lymphomas, then the consideration has been to deferment of therapy wherever possible, the use of perhaps less immunosuppressive chemotherapies. So because of everyone's concerns regarding the T-cell suppressive effect of bendamustine, we've used much less, if any, bendamustine at all. And for example, in indolent lymphomas, particularly follicular lymphoma, we've gone back to using much more CVP, which is not associated with any significant T-cell suppression and has a relatively short and modest duration of myelosuppression. We've also thought a little bit differently about delivery of rituximab and the use of lenalidomide. We've been fortunate in the relapse setting for follicular lymphoma that we're now able to use the combination of rituximab and lenalidomide thanks to NICE approval, and trying to keep patients away from hospital. A good example is to use the rituximab subcutaneously rather than by the intravenous route, and that makes a very nice outpatient based non-chemotherapy regimen for patients with relapse disease, which really minimizes their times in hospital. We thought hard about our maintenance strategies, and for some patients, we have stopped or we have not started maintenance therapies. And all of this, just as the underlying principle, is that we want to try and minimize our risk for patients. How that balance changes as we see, hopefully, a continued decline in the number of patients with COVID, we'll continue redress that. But certainly we have made some really quite significant changes to how we treat patients.